Hi, hello everyone. On behalf of the McGill University Dementia Education Program and Nova Home Care, welcome to Let's Talk About Dementia. This is a free public lecture that aims to raise awareness and provide basic information about Alzheimer's disease and other neurocognitive disorders. So I'm Diane Widener. I'm the Communications and Community Outreach Officer for the McGill Dementia Education Program. In case you're not familiar with our program, it's led by a multidisciplinary team, and we have created a wealth of multilingual educational tools and resources to support care partners of people living with Alzheimer's disease and other dementia-related illnesses. So I'd like to thank Nova Home Care for inviting us to speak with you today. Nova Home Care is a community-based nonprofit organization whose mission is to provide compassionate, high-quality, personalized in-home care to people who are ill or nearing the end of life and families who support them. I'm going to give you a short run-through of what to expect today, today's agenda. So Marianne Simoneau, who's the Director of Philanthropic Development at Nova Home Care, and her colleague Dominique Goyer, who's the Clinical Director and Project Manager of the Home Palliative Care Mentoring Program, will begin today's presentation by telling us more about their organization. Next, Dr. Serge Gauthier, who's a clinical neurologist and the academic co-lead of the McGill Dementia Education Program, will provide information on the different types of neurocognitive disorders. He's going to discuss the associated behavioral and psychological symptoms that manifest as the disease progresses, and he'll explain how this may differ from typical aging concerns. After this, Ms. Claire Webster, a former caregiver and certified dementia care consultant and founder of the McGill Dementia Education Program, will share practical advice on how to care for a person living with dementia. She will discuss important considerations to ensure the safety and the well-being of both the individual as well as the care partners to help families navigate and understand this disease. And finally, we will spend the last 15 minutes of our time together by answering your questions. So if you have any questions, please save them until the end where you can post them in the chat or raise your hand. Please note that we will be recording the lecture today, and it will be posted on the public lectures section of the Dementia Education Program website. We ask that you please keep your microphones muted during the presentation and turn your video cameras off. So thank you very much. And please, Marianne, go ahead. I'm going to stop sharing my screen now so you can share yours.
Oops. Sorry for that. Oops. Okay. Good. So thank you, Diane, Claire, and Dr. Gauthier. Dominique and I are really, really grateful to partner with the McGill University Dementia Education Program. Daily, Nova Home Care helps and empowers people living with dementia and support their caregivers. So we're really thrilled to be here today to introduce you to our nonprofit organization. So let's start with a little bit of history. So as one of the founding branches of the Victorian Order of Nurses of Canada, Nova Home Care has been providing in-home nursing care to the Montreal community since 1898. So Vaughan was founded by Lady Ishbel Aberdeen, wife of Canada's Governor General. So initially, Vaughan was a home visiting nurse program to support local Canadian communities. Last year, we celebrated 125 years of community support. I'd like to let you know that all the photos that you will see in our presentation are from people that Nova helped in the past months. I know that Diane mentioned our mission, but it's important for me to mention it again. Nova Home Care is a community-based, we're nonprofit, and we provide caring, compassionate, high-quality, personalized home care to the people who are ill and those nearing the end of life, and also the families and the caregivers that support them. My apologies, there's a small. All right. Okay. So according to a statistical report from the CREGE, the Center for Research and Expertise in Social Gerontology, and the Social Services, Sciences and Humanities Research Council, there's 71% of senior Quebecers that want to live the end of their life in the comfort of their home. So as you can see, it's a very high percentage. The overall context in which the Quebec society is evolving has a huge influence on the health of its population. So among the major challenges is the aging of our population. So in 2021, Quebec had 1.75 million people aged 65 and over, which represents roughly 20% of the population. In 1971, that was only 7%. So it has been constantly increasing since then and will rise to 26% in 2041, according to the Quebec Statistics Institute. So in Quebec, the people living with neurocognitive disorders could jump by 145% by 2050. So over the past years, as if you've been following the news, the topic of home care has really been all over the media. It's really a topic that concerns all of us. Last week, Quebec's Health and Wellness Commissioner, Joanne Castonguay, released a striking report, which revealed that the growing imbalance between the provision of home services and the needs in our community. She also mentioned that the research revealed that seniors want home care and also that the costs are significantly lower for taxpayers than sending the people to the hospitals. So home care provides physical, emotional, social comfort to people living with disabilities such as dementia. So it helps people remain active while maintaining a certain degree of freedom. And that's quality of life. And to us, providing that daily is essential. So bottom line, the demand for home care will continue to grow. And I will throw the ball at Dominique that will discuss our services.
Thank you, Marianne.
You're welcome.
So let me present to you a little bit about the care and services provided by Nova Home Care, which is the palliative care program and the home support program. Before, let me tell you, though, a little bit about the territory that our organization covers. We offer care and services on the island of Montreal in Quebec, and more specifically in collaboration with 3 CIUS. As you can see on the map here, Nova covers a part of La Salle, Nuns Island, St. Henry, Côte-Saint-Luc, downtown of Montreal, and town of Montreal. We actually have service agreement with those CLSC and work very closely with them to improve the quality and the accessibility of care to the community. Nova has been providing palliative home care services for over 30 years in the community. The care and services include nursing care, home health aides, massage therapists, and social counseling for the caregivers. We also work in collaboration with other organizations such as La Fondation Jeanne Mance for spiritual care at home. Nova's focus in this program is really to allow every person with a life-threatening illness to stay at home as long as possible while receiving the right care in dignity. Nova's nurses are available from 8 a.m. to midnight, 7 days a week for counseling, support, and symptom management too. The people in this program suffer from various illnesses such as cancer, but also chronic terminal illness, for example, end-stage heart failure or kidney failure, and also terminal dementia or nervous system disorder. We also offer more support, for example, overnight shift by a nurse near the end of life if the person wants to die at home. We recognize how much the caregiver are important and needed in home care. The other program we offer to the community is the home support program. So it is intended for all people in our region who have a fragile health or with a loss of autonomy impacting their daily and domestic activity. The majority of people in this program suffer from various stages of dementia, and 98% of them are receiving care and support by a family member. As you can see, most of them are over 25 years old, and 60% were women last year. The care and services offered are designed for both the in-need person and also for the caregiver. Our focus is to help the person through personal hygiene, for example, mental well-being, stimulation activity according to their needs and hobby, and also to support the caregiver in their role throughout the course of their loved one illness. This results in in-home visits for the person by the same home health aides every week to ensure the needs and to also maintain the continuity of care. Nova Home Care gives 2 blocks of 3 hours per week free of charge. It also results in individual psychosocial support by our social worker to the caregiver in line really with the needs of the caregiver. We know that supporting caregivers, we know that the support of caregiver can vary from one person to the other, and we really want to focus on that.
So Nova's impact in the community is significant. So for the last, like I mentioned before, 125 years of, being there for the community. I'd like to bring your attention to the statistics regarding our home support program, as the majority of people in this program suffer from various stages of dementia. So last year alone, there was 12,000 hours of services that were offered by our 14 home health aides. And we had a 23% increase in the number of people in our home support program versus the same period last year. So as you can see, the needs are skyrocketing. And last year, more than 1,000 people have benefited from our free services. So why support Nova? Well, there's a really, really long list, but we were able to, shorten it a little bit. First and foremost is access to home care. It should not be a luxury. It should be a right. This access should be possible. It should be free for everyone, regardless of their postal code. And that's a priority. So Nova's proud to be part of this, solution to a major health issue. And we ensure that home care with high quality services and preventing hospitalization. So ultimately, the government wants the same thing as us. So we have, lots in common. That's why this public and private partnerships can work and solutions are possible, and Nova Home Care is a great proof.
Nova Home Care have also a mentoring program, which I would like to tell you more about it a little bit. So we developed a training in 2019 for nurses practicing in home around Quebec and who wants to improve their knowledge of palliative and end-of-life care. This training is free of charge again and accredited by la Faculté des Sciences of Nursing la Faculté of Nursing de l'Université de Montréal. And since it started, nurses not only in home setting, but also in CHSLD and hospital have taken the training. We also train family doctors and other health professionals. We actually train more than 500 people by this time of year. It is offered in person or in video conference, depending where they are locating the trainees. We believe that nurses play a major role in maintaining a person at.
So I'm so grateful and fortunate because Nova and myself get to receive a handful of beautiful and touching testimonials from patients, from caregivers. We receive them from our community partners and the health practitioners that we work with. And as the time is limited today, I can only present a couple. So there's wonderful connections that have been developed with so many families who have been generous enough to confide in me and Nova. So great example of that was with the Mastro Pasqua family. So every time I spoke to Lucy, which is Mrs. Mastro Pasqua's daughter, over the phone, she referred to our clinical team as a team of angels. So this beautiful picture of Edda, which I believe she looked so peaceful, was taken in her home just a few days before her passing. And another great example is Nova's help to this family, this couple. So Mr. Dimuro has had dementia for a number of years, and he's living at home with his wife, Odette, who's a primary caregiver. So for the past 6 years, Nova has been a life-saving service, according to Odette. And every time I speak to her, she tells me, how much it has made an impact and how much light our team was bringing to her daily life. So for caregivers, the home care services are essential. According to l'Appui Proche Aidants 2022 statistical survey on caregiving in Quebec, each week there's 46% of caregivers support their loved ones for 5 hours or more. There's 60% of people who give more than 20 hours per week that are women. The most important services for caregivers include support for the daily care and the individual psychosocial support. So both services are offered by Nova Home Care. And as you can see, Nova's team is filled with caring and passionate individuals. That's the proof. So you're more than welcome to contact us at any time, and please feel free to visit our website or visit our LinkedIn page or Facebook page. There's a lot of news articles that are coming out in the media on a regular basis, and we post them. So please follow us. Please, comment also. We are always so happy to connect with the community. And thank you so much for your time. Dominique and I really appreciate it. And we were very grateful. We are very grateful to be here today.
Wonderful. Thank you so much, Marianne and Dominique. That was a lovely presentation. And thank you to your team of angels. Just going to share our little slide here. Perfect. All right. So I'd like to introduce Dr. Serge Gauthier. Serge Gauthier is the academic co-lead for the McGill Dementia Education Program and Professor Emeritus in the Department of Neurology and Neurosurgery and the Department of Psychiatry at McGill University. He's a clinical neurologist and researcher who specializes in the development of new tools for diagnosis and treatments of people living with Alzheimer's disease. Dr. Gauthier completed his medical studies at Université de Montréal, his neurology training at McGill University, and a research fellowship at the Allen Memorial Institute. He was the director of the McGill University Research Center for Studies in Aging from 1986 to 1997, and director of the Alzheimer's Disease and Related Disorders Research Unit of the MCSA until 2021. He was also a senior scientist of the Canadian Institutes of Health Research and Development from 1997 to 2007. Among his numerous prizes and distinctions, Dr. Gauthier was appointed to the Order of Canada in 2014 and the National Order of Quebec in 2017 for his contribution to advancing our understanding of Alzheimer's disease and dementia, and for fostering the development of research networks in his specialty. So as you can see, you're really in great hands today. Dr. Gauthier, please go ahead.
Merci, Diane. Good afternoon to you all. Next slide, please, Diane. So this is the topic of today, understanding neurocognitive disorders, and this is the content. So we'll just look at this together briefly so you'll know the flow in the next 25 minutes or so. So I'll clarify from you right from the start, what is dementia, what is mild cognitive impairment, and what are the stages through the continuum of a disorder such as Alzheimer's disease. I will also explain briefly the difference between Alzheimer and other causes of dementia. I will mention how the doctor, whether it's a family doctor or a specialist, talks to you and the family. How do we probe into symptoms and how it leads into a diagnosis. There's some complementary laboratory tests. I'll show you examples of brain scans, for instance, that helps to find the cause of the dementia. And just a word about how we disclose the diagnosis and how we initiate management. And that includes some medications for selected symptoms. There's new medications coming. I'll mention them briefly. And then bridge with a class talk, which is the long-term care management that goes well beyond the strict medical diagnosis and treatment. So next slide, please. Some definitions. Next slide, Diane. So a word about early detection. So there's still a stigma associated with the diagnosis of dementia. In some cultures, not so much in Canada anymore, but in some parts of the world, dementia is still has a psychiatric connotation. And a new term that is coined is neurocognitive disorder. So I'll come back to that in a second. The other big change is we can make a diagnosis of conditions such as Alzheimer's disease even before dementia sets in. So all this to say, if you have symptoms, see your family doctor or a group of health professionals working together, such as the MINT, M-I-N-T, clinics in Ontario. And they will go through the symptoms with you as we are doing right now. So early detection could mean early treatment if you have a specific cause. And it could also mean treating concomitant disorders, whether it's heart, arrhythmia, or decreased hearing, or low thyroid function, lots of things we can do. So please, if there's one message from today, if you have any kind of cognitive decline, whether it's your memory, looking for words, just see your health professional and we'll sort it out. Next slide. So normal aging. So I'm now 73, so I have some of these symptoms, and I'm sure a good number of you in the audience have these little lapses. What's his name again? And then it comes back later. That's normal. Where are my keys? That's normal. But if you forget what the keys are for, that's a different thing. We are a bit slower at processing speed. So sometimes we think, we pause before we answer, and it's normal. It's called wisdom in some cultures. Sometimes we hesitate, not just the name of someone, but the word of common objects. Sometimes we use the wrong name for the grandchildren. That's fine. That's still normal. Good judgment is preserved, especially for tasks that you're familiar with. So if you were always good with numbers and finances, this will last a lifetime. But if you were never handling finances, don't expect to learn at a late age. Functional independence usually is preserved, even in late life. I know people in their 90s who are living alone and well, they just have to be sure not to trip on ice and etc. So as many of us are aging beyond the old age of 72, 73, we're well expected many of us to live into our 90s. There will be lapses for names and where are my keys and what's the best way to get somewhere when driving. That's normal. But then there's a gray zone of where symptoms change, and we're going to talk about that now. Next one. So, definition. This is the old definition of dementia. The new term for it, especially in Quebec, is major neurocognitive disorder. It's part of the DSM-5 classification for diseases. And the old definition is a decline in intellectual abilities. Memory was always involved for Alzheimer's disease, but it's no longer the case. It could be vision as early symptom. It could be finding your way around, looking for words. So there are different symptoms that could appear as you start even a condition such as Alzheimer. And the other big thing is the complaints you have, whether it's memory, looking for words, etc., it must interfere with your daily life in a significant way. And there's a cultural component, gender component, what you used to do, can you still do it? And if you never did it, you don't expect now to be able to do it. The other big factor is anosognosia. It's a term that Claire may refer to. It's the lack of insight by many people who have early Alzheimer. There's nothing wrong with me. It's my family who's saying there's a problem. And this is a cause for delay in seeing a doctor. And it's not unusual at all to have a person with early cognitive symptoms coming with a family member or friend, because it's hard to remember actually what your symptoms are if you have early dementia. Of course, people may partly realize what's happening. They're losing some control over their life in some subtle ways or not so subtle ways. So yeah, it generates anxiety, and depression may be mixed in the early cognitive symptoms. Next slide, please. So the causes are multiple. So in our current generation, Alzheimer's disease is the most common cause of dementia, but there are people before the age of 65 with Alzheimer and other causes, such as frontotemporal dementia. Young or old, you sometimes see a mix of Alzheimer and stroke or Parkinson-like changes. We'll talk about that briefly as we go along in my differential diagnosis. So just be aware that even if we say someone has a major neurocognitive disorder or a dementia in mild stage, we may not be sure of the exact cause, but there's good news here I'm going to share with you. For at least for Alzheimer, we have some ways to be absolutely sure this is the cause of your symptoms, and there's new treatments for that. Next, please. Potential symptoms of dementia. So we're now moving from the normal aging into when you should worry. And it may not be you who worries, it may be the spouse or the children. So memory loss interfering with daily life, such as she forgot to pick up the grandchildren at school a couple of times. Difficulty solving problems. So someone who was good with handling finances, deciding which account to put money into, etc. Now there's been some mistakes. Confusion for place. So she or he went to the wrong place to pick up someone. Instead of the hairdresser, he went to somewhere else. Looking for words, but in significant ways. Enough that you sort of have social withdrawal, you're embarrassed, or you have trouble following the conversation of other people. So there is a bit of social withdrawal. Poor judgment we mentioned, especially about finances. Personality and mood changes. Again, it could be a reaction to the loss of autonomy, even still subtle, but it could be more dramatic. And there are some specific causes of dementia, such as frontotemporal dementia, where behavioral changes are first and paramount rather than cognitive decline. Difficulty completing familiar tasks, so I'll come to that in a second, and withdrawal from social activities. This may be something you as a neighbor or a friend may notice, like playing cards. Someone was very good at playing bridge. Now they don't even go to the weekly bridge games because they just can't remember the contract. This would be considered a significant change from normal aging that deserves a full workup. Next, please. These are the examples of the things that the physician or occupational therapist or nurse would probe. These are the specific activities of daily living that change early in the course of a condition such as Alzheimer. So mistakes in handling finances in someone who was good at it, difficulty planning a meal in someone who was good at it, planning an outing, remembering where the car is parked. Of course, it happens to all of us at Dorval Airport or wherever you live, airport. But so you take a picture of the post next to the car, H2, level P2. That's how I remember. So there's a way you compensate for your age-related lapses. And then there may be, that's a less common, difficulty with visual recognition. You don't recognize people or where you are as much. This would be something unusual, but that can happen in the back of your brain. So these are the examples of things we can ask about when you visit the memory clinic. There's a checklist that has been designed by occupational therapists at McGill University. So there's different ways to probe into these early changes in your day-to-day activities. Next slide is about non-cognitive and non-functional changes. In other words, behavioral symptoms associated with dementia. And this is a partial list. There's a very important scale, the neuropsychiatric inventory, that has 12 items. But the most common things Claire and we hear in our practice is conspiracy theory. So let's say you cannot find your money because you forget where it is, and you, of course, think somebody else took your money. That's a common complaint. Mood swings, that could be more prominent in people who had strokes or have early frontotemporal dementia. Disregard for personal grooming, personal hygiene, that could be very, very early change in frontotemporal dementia. It's a later change in Alzheimer. Delusions and paranoia, and you can add to that visual hallucinations, can be occurring early in the course of the Parkinson dementia or dementia with Lewy bodies. So all this to say, these various symptoms can help in the differential diagnosis of the cause of dementia. But of course, some of them have a big impact on the quality of life of the individual and the care partners. Visual and physical, verbal and physical aggression, it can be a late feature of Alzheimer. It's not occurring in everyone, of course, but this is often a cause for moving from home to assisted living. And sleeping difficulties, so-called sundowning, syndrome du crépuscule, is common also in Alzheimer's disease. So that's a partial list. We'll see in your questions if you have specific questions about selected symptoms. But these behavioral symptoms are not usually so present at the early stage of dementia, except frontotemporal dementia and unusual presentations of Alzheimer's disease. Next one, please. This is an illustration of the usual sequence in Alzheimer's disease. Mood changes may precede cognitive decline. In other words, you may have social withdrawal and mood swings and anxiety before you have memory complaints that are picked up by your family members. And then there's a gap between memory complaints and interference with daily life. And then in Alzheimer's disease, that's typical. The big behavior manifestations are later, 3-4 years after the diagnosis, with agitation at night, etc. And then they get better over time. And then there is a last stage Parkinson-like phase of Alzheimer where you have muscle rigidity and you fall and you have trouble swallowing. The next slide. So now we're going to look at pictures that were made as part of a book that Claire may tell you about later that is available online in multiple languages. It's a sort of a companion to families, and so the person with symptoms and care partners. Multiple illustrations such as these are there to help you understand the stages. So this is meant to be an active person. She's multitasking on the phone, doing her billing online, and she made her coffee. Okay, she's normal. Next slide. Now, what's my password? Isn't that happening to everyone? Okay, but you know where to find it, right? So that's it. That's subjective cognitive decline. I did forget my passwords, but I have a way around it. That's normal. Next one. The daughter now is getting worried, or the person living with you is getting worried that you did forget things and it has an impact on daily life, and it's progressing over, let's say, 6 months, and it's not just like an acute infection and a bit of confusion and so on. Next slide. Now you really need help for your finances. So now we're talking about mild dementia and difficulties in daily life. You need supervision here for finances. Next one. Now you need help for getting dressed. So now we're talking about moderate stage dementia. You need assistance for basic activities of daily living. So that's using the shower or bath safely and choosing the clothes, etc. And another stage, next one, a more advanced stage where now there's a physical component to the illness. So now you need help to go out. You're at risk of falls. So these are ways to illustrate the stages, and the booklet that we've rewritten helps you understand these stages and how to adapt. The next one, please. So you come to the doctor. Notice that depending where you live in the world, people come at various stages. In Canada, especially in Quebec, people can come at the very early stage. They're just worried. We call them worried well. That's fine. Then we talk about prevention. They could also be coming with someone, but most of the complaints are from the person, not from the family. So that's subjective cognitive. There's no dementia there. Or if they come with someone reluctantly and someone else is saying, look, she forgets. Okay. And another stage, they come because there's behavior changes at home. We're well past the early stage. So people can come for diagnosis at various times in the continuum that we've just illustrated. So history. We need a family member or friend, a physical exam, neuro exam. The MOCA is used. I'll illustrate what the MOCA is in a second. It's the #1 test in the world, thanks to Dr. Nasreddin, who created this here in Montreal, a Montreal Cognitive Assessment. The other test is the mini mental state examination. It's also used worldwide as a way to assess cognition in 5-10 minutes, and complementary tests as required. I'll talk about that now. Next slide is an illustration of the MOCA. So this is something you can find online, but please don't practice just before you go for the test, because then what's the purpose? But this is to show you what it looks like. It's out of 30 points. And you have at the top tests that have to do with executive ability, your ability to think quickly, to draw, then name some animals, and then remember 5 words, some distractions, serial 7s. What were the 3 words? And then the date and time, etc. So out of 30 normal people over age, any age, 26 and above, you're normal. Below 26, it could be because you're anxious. The test is causing some anxiety, or you had a bad night, or you're taking the wrong pills that affect your memory. Many things can lower the score. So the score alone is not how you diagnose dementia. It's history. Then you get a measure, and you may have to repeat that test 2-3 times before you see a decline, or it's stable, or even improvement. Next, please. Other things we do is blood work, the same that is normally done for the annual checkup. If we still do that, if you have a family doctor, lucky you, well, he or she will usually order these blood tests once a year. Of note is the TSH. It's a way to measure thyroid function and glucose if you're diabetic. And the CT scan, computer scan, or the MRI are usually done. In our culture, there's no injection required. It's just a scan to look at your brain, and we look at the size, and is there a tumor? Is there too much water? Are there little holes? One big hole? I'll show you what we actually look at more specifically. Next slide. So this is an MRI, different people, obviously, and 0 to 4 refers to the size of this structure called hippocampus. It's the name of the structure circled in red. We have 2 of them, and they shrink a little bit with age. So that's why we are a little slower to remember names and what we're supposed to do, but we compensate, right? But you can see it. You can give a score. So this is one of the things we can see on the MRI, in addition to small strokes and shrinking of the brain, etc. Next one. The other tests we do a lot in Quebec, not in the rest of Canada, unfortunately, is a PET scan, positron emission tomography. It's used also in Singapore. I know there's at least one listener in Singapore today, thank you. It's called fluorodeoxyglucose. It's a scan that's used a lot in oncology. It's injection in the vein in the arm of radioactive glucose. For cancer, it will tag on to a tumor. For brain, as I will show you in a second, it shows where the brain is active. It shows where cells, synapses are active. And it's often done for younger people, younger than 65, or people with atypical presentation, such as looking for words a lot rather than memory problems. And I'll show you a slide now, next one, what it looks like. So this is readily available. It could even be prescribed by family practitioners. And you see in red in the middle, normal. The red means a lot of glucose being used in that person. And on the right, you see with the arrows, there's much less redness. So there's less cell activity, less neurons, less synapses. And that's a signature of Alzheimer's disease in the context of history and decline in memory tests, etc. Not just a picture alone. It has to be always in the context. Next, please. Another test that's done is lumbar puncture. So spinal fluid examination, we can measure various proteins in your spinal fluid. It's done in many clinics across Canada now, especially in young people, younger than 65, or people with atypical presentations. And I'll show you in the next slide what proteins we measure. Next one, please. So A-beta 42 is the one that increases in the brain for 20 years before you get Alzheimer's symptoms. But it's low in the spinal fluid because it's stuck in the brain. You cannot clear it. So paradoxically, when you do a spinal tap in someone who may have Alzheimer, this protein is low because it's stuck in the brain. Tau is another protein that's leaking out of damaged neurons. So tau leaks out of damaged neurons, but it's not specific. If you have a head injury, tau will go up. If you have an infection, meningitis, tau will go up. But phosphotau is up only in Alzheimer's disease. So with the spinal tap, you get all three measures. So you get more bang for your bucks, to speak like an American. You get more results from a single test. Whereas if you do a PET scan for amyloid, you see the amyloid, but you don't see the tau. If you do a PET scan for tau, you don't see the amyloid, etc. So one scan, such as an MRI, plus a lumbar puncture, that's the best way to finalize a diagnosis of the cause of dementia, especially in younger people, younger meaning younger than 70. Next one, please. So the patient comes back with the family and we put the information together. Is there a clear evidence of cognitive decline? Was it just like a 2-week thing and then things got back to normal? Does it interfere with daily life? Is there depression mixed in? Are there other conditions explaining some of the symptoms like low thyroid, low B12? And are there drug side effects? Is the person taking medications interfering with memory? Next one. Now, some criteria quickly. When we say it's probably Alzheimer, it means that you've ruled out other conditions. The person has evolved over 1 or 2 years in a way compatible with Alzheimer. But now we can do better than that. We have, next slide, a biological criteria for Alzheimer. So if you wish, you can ask for lumbar puncture, and we will measure those proteins, A-beta 42 and tau, and we will be able to say you have A, amyloid in your brain, T, tau, and there's a bit of shrinking of the brain, N. So these are the new research criteria for Alzheimer, and it's going to be used in clinical practice very soon, especially since the new drugs that are coming require this kind of accuracy in the diagnosis. And next one, just to look at the other causes of dementia, vascular dementia. It used to be more common before the 1970s, much less common now. It could be one small stroke in the strategic part of the brain. It could be multiple strokes all over the brain, very rare now. It used to be related to untreated hypertension and diabetes. And what we see more now is small strokes mixed with Alzheimer. We call it a mixed dementia. Next, please. Parkinson and Lewy bodies. So Lewy bodies is unusual because you have early visual hallucinations as one of the early symptoms. You have fluctuations within the day, and you have sometimes Parkinson-like stiffness. And unusual. They have difficulties at night. They wake up and during the dream period, people shuffle in bed, and it's called REM behavior disorder. So that's one kind of dementia. And the other one is Parkinson. The next slide. I think we have it there. Yes. So Parkinson's disease dementia is a way to say that if you have Parkinson's disease for a number of years, 5-10 years, there is a slowing down of your cognitive abilities, and it could progress all the way to dementia. It's not the case in everyone with Parkinson, but there's research interest in this because we may be able to perhaps prevent the dementia part of Parkinson in time. Next one. Maybe we skip the frontotemporal. I'll just say a word about that because I know there's at least one listener who's interested in that. This is a rarer kind of cause of dementia. Frontotemporal means frontal, temporal parts of the brain are affected first. Half the people, they have trouble with words if the left side of the brain is affected first. And the other half, it's more frontal, meaning behavior changes. And it could be genetic or not. So now we have gone through the differential diagnosis together. We have to tell the person with symptoms and the family what we think. This is dementia. The cause is probably this, or for sure this, because we did a lumbar puncture. And then we plan ahead together. That's called disclosure. We need to answer truthfully to the questions raised by the person with symptoms, unless there's a real concern that it will lead to a catastrophic reaction, like a suicide gestures, etc. This is very uncommon, so we should answer truthfully, like for cancer, to questions that are raised. Next, please. Management, so education. So this is possibly not done right away at the time of disclosure. We may need to have extra time set aside with another staff person. Claire will talk about that. Next slide is plan for needs across stages. I hinted that there are various changes over time, and ideally we should plan with you because things will evolve over time. Next one, coexisting conditions. So family doctors are very good at this because they are usually handling the diabetes and the arrhythmias, and this is very important, especially over age 85, where the Alzheimer condition may be not so important compared to heart and stroke risks, and it's managing the person as a whole, medically speaking. Next is the old medications. We've had them for some 20 years, antidepressants, cholinesterase inhibitors, donepezil, rivastigmine, galantamine, and memantine. They're available and prescribed by family practitioners. The last category we don't like, but sometimes we need them, antipsychotics for behaviors that cannot be managed with non-pharmacological approaches. Next one, new medications coming. So I'll just mention two words, lecanemab, donanemab. These are intravenous injections done every 2 weeks or every month. It's about to be approved in Canada. And then we have to think of how we're going to give those infusions and who needs them. And then there are experimental medications addressing the tau buildup. And there's more research coming for the inflammation component of conditions such as Alzheimer. And next slide. Non-pharmacologic treatments, just a hint that there's a lot we can do beyond the medications for symptoms. So physical exercise, very important. Cognitive training, or just cognitive stimulation, being with other people. Socialization. Next slide. Okay, and if you want to read in depth, we have two World Alzheimer reports available free online. One is about the diagnosis and one is about management. So if you want to probe further into what we just discussed, please get these out of the ADI, Alzheimer Disease International website, or our DEP website. And the final word, which I was asked to say, look, there are prevention factors. There's 12 of them. This is the World Alzheimer Report of this year, 2023. So please pay attention to what is preventable in your life. And that starts with being here right now, listening. You're already gaining something because you're learning and you're sharing with us. So that's socialization as well. So Claire, take it away.
Wonderful. Thank you so much, Dr. Gauthier. I'm just going to take a few words to introduce Claire before she speaks. So Mrs. Claire Webster, she's a Certified Dementia Care Consultant and Certified Professional Consultant on Aging, as well as a conference speaker and educator in the field of caring for an individual with dementia. Claire works in collaboration with McGill University's Faculty of Medicine and Health Sciences and the Division of Geriatric Medicine. She's the founder and ambassador of the McGill Dementia Education Program and McGill Cares, a webcast series designed to support family care partners. Claire is also the founder and president of Caregiver Crosswalk, a consulting firm that provides education and support services to help individuals navigate the journey of Alzheimer's disease or dementia-related illnesses. And Claire is also a member of the Government of Canada's Ministerial Advisory Board on Dementia and one of the McGill senior co-editors of the 2021 and 2022 World Alzheimer reports that you saw Dr. Gauthier refer to earlier. As a former care partner to her late mother, who had Alzheimer's disease, Claire has lived experience about the impact of the illness, the impact it has on the person, as well as the ripple effect on the family members. Go ahead, Claire. Claire, are you sharing your own slides?
Yes, I will.
Okay.
I'll just share my
Perfect.
screen and then I'll just pull up my presentation and there we go. You can see it all.
Perfect.
Well,
Yeah.
perfect. Well, thank you, Diane, for that introduction. And I thank you to my colleague, Dr. Serge Gauthier. It's always wonderful to work together and present this journey. And so as Diane mentioned, I come from this not only from a professional standpoint, but from a personal standpoint. I was a caregiver to my mother, who was diagnosed with Alzheimer's disease in 2006. And at the time, I knew absolutely nothing about dementia. I guess in life, sometimes our journey is what brings us here. And I think that was that unfortunate journey that I had with my mother, just not being prepared, that led me on this path to help others. And so it was really these words that led me on to the work I'm doing today. That was the prescription of care that we did not receive upon learning that my mother had Alzheimer's disease. That's all we got. My mother performed the MOCA test, as Dr. Gauthier mentioned. We're showing some symptoms, which I'll discuss, but basically that's all we were told. We were told good luck. Not, here is some information, here is what you should do next. And that was back in 2006. And I've worked with hundreds and hundreds of caregivers. And unfortunately, that's still the case. And imagine getting a diagnosis of heart disease or cancer or diabetes, and all you're told is good luck. So this is why we developed this program at McGill to try to change the way that patients will be educated about this illness in the future. So unfortunately, there is no cure. And so what's most important is really education. It's about being one step ahead at all times about this illness. It's about understanding if the person is in the first stage of the illness, what's coming next. So education is key, understanding the symptoms, understanding the resources that are available to you. So attending webinars like you are today are of utmost importance to take the best care possible of the person. So I'm fortunate to work with a great team at McGill. In addition to Dr. Serge Gauthier, I work with Dr. José Moret, who's head of the Division of Geriatric Medicine, and Dr. Pedro Rosanetto, who is at the McGill University Research Center for Studies in Aging. He's a neurologist who specializes primarily in early onset dementia. So that means people under the age of 65. So we work as really as a team together. And we have a lot of resources that will be a complement to the webinar today. I encourage you, Diane will put it in the chat, but I really encourage you to go on our website. We have virtual support groups. The World Alzheimer's reports that Dr. Gauthier mentioned are there. We have all kinds of lectures. I'll even be introducing a new program that we launched just last week. Most importantly, Dr. Gauthier referred to the Dementia Companion Guide. Everything that we are talking about today is available in this guide. You can download it for free. It's available in 12 different languages because dementia doesn't discriminate. So we're trying to make our resources available to as many, to as much as a multicultural population as possible. And printed copies are available on Amazon, and all proceeds go to support our program. So please, I encourage you all, this guide is absolutely invaluable. So the reports Dr. Gauthier mentioned. So as we were writing the world reports, one of our mandates was to conduct a survey of care partners and persons living with dementia all around the world in order to gather our information. And one of the questions that we asked was, what were the difficulties that you encountered as part of receiving the diagnosis? And what came up was exactly what I've experienced, and I'm sure many of you who are here today, was the lack of information that was not provided to you. So you may have been told there are some drugs that could help manage some symptoms of some moods, or, maybe there's some resources, but actual information about the illness and how it was evolved, there was a real lack. And this is not just on a provincial level, this is globally. So what is the information that we don't have? So these are the questions that I get a lot, and the questions that I too had as myself as a care partner. So basically, just understanding the signs and symptoms, right? Everybody thinks that dementia equals memory loss. That's not so, right? So it's really the lack of information about the signs and symptoms, the lack of understanding the importance of seeking a diagnosis, the how to get the pathway of getting a diagnosis. Some of you may or may not have a family doctor. Some of you may or may not have a geriatrician. Sometimes the family doctor may not have received training in dementia, so he's not able to make the diagnosis. So you'll have to be referred to either a neurologist or a geriatrician. So it's that whole, like, how do I get that diagnosis? Many people don't understand why people are behaving the way they are. So when they're repeating themselves multiple times, how do I manage that? How do I have the patience to cope with when my loved one calls me 50 times a day, or why are they getting angry? So it's all that, how do I manage those behaviors? And then there's this disease brings a lot of safety concerns, which I'm going to discuss. And then, just because you receive a diagnosis of dementia doesn't mean that life is over. There are all kinds of leisure and recreation activities that a person can participate in, which I'm going to demonstrate afterwards. It's important that everybody wake up in the morning and have a sense of purpose. It's important to continue to participate, to stay socially stimulated, to participate. So we're going to show you something about that today. And also, how do we navigate the healthcare system? For those of you that are not only in Quebec, how do you access services from the public healthcare system? How do you access services from the private? What is the difference between a public residence versus a private residence, right? So it's how to access those support services in my community. And most importantly, caregivers don't recognize their own boundaries. Like, when am I on the verge of getting a burnout? When is it becoming too much for me? As much as I tried to keep that person at home, when is it no longer possible? So those are the common points that come about with almost everyone. Now, Dr. Gauthier mentioned the word anosognosia. This is a challenge for families because anosognosia means a loss of insight. That is that we as the family members are seeing the changes that are occurring in the family member, but they believe there's nothing wrong with them, okay? So why this makes it difficult is because when you're noticing enough symptoms and you want to bring your loved one to see a doctor, they are refusing to go. It could also mean that they have conspiracy theories, as Dr. Gauthier mentioned. Somebody's stealing money, somebody's cheating, and you're trying to explain to them that it's not true. But in their mind, it is very, very true. Like, somebody wrote to me ahead of time and said, my father is feeling completely paranoid of the caregiver coming into the house. In his mind, that's really real. And it doesn't matter how many times you try to explain that to the person, it is what they believe. So instead of arguing with them, you have to try to come to a place of compassion, try to be understanding of them. Because I always say anosognosia, you're not speaking to the person, you're speaking to the dementia. So dementia causes this illness. Now, it doesn't cause it in everybody, but it does cause it in many people. So I just wanted to show you some images of my own journey with my mother. I was a sandwich generation caregiver. So I started caring for my mother. I was about 38 years old. My father had died in 2005 of congestive heart failure. And, a couple of years before my father passed away, he started telling me that there was something wrong with my mother. Now, my mother was a caregiver to my father my entire life. He did not have dementia, but he had all kinds of physical ailments, also depression. And so she was under a tremendous amount of stress. So when he was telling me that there was something wrong with my mother, I blamed it on her own stress. So these are photos of the early stages. And as you can see, she looked fine. And I think for many of you, that's what's hard, right? Because at the beginning, the person still looks fine. And when you try to explain to friends I remember trying to explain to a friend of my mother that my mom had dementia, she was accusing me of making this up, right? Because she looked fine. So at the time, as I mentioned, I was an only child. I had 3 young children. I was working in another field. Sorry, I'm just going to go to another. Actually, I can use some of these examples. So what were some of the symptoms that I saw from my mom when I go back to this? Well, I think it really started with a change in her behavior. After my father passed away, she started to become very depressed, which I thought was okay, that makes sense. You know, she had been a caregiver most of her years for him. I noticed there was a change in her vocabulary, the way she was speaking. Now, my mother was Finnish, so she kept flipping back between English and Finnish, really having a hard time finding those words, you know, naming glasses, naming things. You know, she started hoarding items. So she was collecting all those blueberry and strawberry containers, like just hoarding numerous items. But it was really when she started making substantial financial errors that I started realizing something is off. Every single charity that mailed her a request for money, she wrote a check for. And my mother was not a wealthy woman, and she would write checks for $25 to absolutely everybody. Then she started having minor car accidents. She was also convinced that Al-Qaeda was living next door. They were living in an apartment, and Al-Qaeda was living next door, and she would stand at the peephole looking out when it was actually the mailman coming. You know, it was the way my mother was a big tennis player. And in August, when I would take her to the Rogers Cup, she was wearing high heel shoes and a big winter coat to watch the tennis. And, you know, I was noticing more and more that things were going on. And I really have to say, I didn't even know what type of doctor to take her to see. You know, do I needed to take her to see a psychologist? Like, who did I see? So that was when I took her to the family doctor. We went to the neurologist. And I was not prepared. Didn't arrive with a list of symptoms. I thought that the neurologist was going to be able to tell us what was wrong without knowing anything about us. And it was when I started describing the symptoms in the car accident that, without warning, he picked up the phone and called the Automobile Association and canceled her license without any warning. And you can only imagine how devastating that was. So when Dr. Gauthier described the symptoms in the first images you saw, that was the early stages. The second stage is really, I mean, if you look at her eyes, there's a change that happens in the eyes. And I think for care partners, what's really difficult is what we call that anticipatory grief, right? So you're mourning a person while they're still alive. So this is really what the last stage is like. Again, you know, the beginning stages, it's very cognitive. The person's asking you, repeating themselves over and over again. The second stage, they're having more difficulties with their activities of daily living. And the end stage really represents full-time care. At this point, my mother was transitioned to a long-term care facility. And you could see in the eyes at the end, she wasn't sure who I was. So it really, you know, it impacts the caregiver because you're constantly witnessing the losses that are taking place cognitively and physically. So when you're having somebody still at home, what you really want to be concerned about is their safety, okay? And every room in the house poses different risks. And in our Dementia Companion Guide, we really took the time to highlight room by room the safety issues that could happen. So when we talk about safety, for example, I would recommend, if for those of you that have somebody at home, you know, loose carpeting, right? Everybody has these loose carpets that are around. Is there a potential that a person falls? Because dementia affects a person's vision and it affects a person's mobility. As the disease progresses, our vision becomes narrower and narrower and narrower. And the mobility, some of you may noticed already that your loved one is starting to shuffle. So if they get up, the room isn't well lit, they're not seeing around, is there an opportunity for them to trip and fall, right? Are there cords lying around? The kitchen has all kinds of dangers, for example. Would they be able to put something in the microwave oven instead of pressing for 30 seconds, they press 3 minutes? Would they put something into the microwave that shouldn't be there? Would they get something out of the oven without using with the gloves? A bottle of Lysol could be mistaken for a bottle of olive oil, right? And what I've seen in my own experience with my mother is, because she was living alone, tons of expired food in the fridge. You know, just again, the hoarding, buying too much of one thing, not being able to cook for herself anymore, right? So again, the bedroom, we need to be careful. that at nighttime, is there anything that could be on the side of the bed that they could fall? Are there any like slippers, or is there any risk again of tripping over carpets, hitting their head on the night table? Are there medications lying around that they shouldn't be taking? Cigarettes, glasses of wine, right? So you really want to be careful. And of course, the bathroom, most of the slips and falls happen in the bathroom. So make sure that there are mats. As the disease progresses, it becomes more difficult for someone to take a shower. For whatever reason, the feeling of the water makes a person feel very vulnerable. Again, clear out your medicine cabinet of things that shouldn't be there. At a certain point, the person should not be taking their own medication. It should be given to them. You know, polysporin could be mistaken for toothpaste. So be very, very careful, and make sure all the hallway that you have some night lights put on, because we really want to avoid the risk of falling. As Dr. Gauthier also showed, the safety doesn't only involve physical safety, it could be financial safety. And the early seeds of dementia, people do start making big financial errors. And if, I don't know about you, but I get all these fake phone calls from the police wanting to come and arrest me, or Netflix update my account, or Amazon this. And so even when you're cognitively healthy, it's hard to differ between something that's real or not. So I always recommend to families when I work with them that if the person is already showing signs of cognitive decline, it's important for the other family members to take over their finances. You really need to protect the finances, because unfortunately, as the disease evolves, it really becomes expensive in terms of, you know, you may need to get some extra home care support. You may need to temporarily have somebody in a private residence if there's a long waiting list for the public residences. So you want to protect the person's finances as much as possible. And then when it comes to driving and also finances, when it comes time to remove that from the person, you really should work with the doctor. It shouldn't come from the family members to say to the person, you can't have credit cards, you can't manage your finances, and you need to stop driving. You have to work with the doctor to do this, okay? Because imagine you are taking away a person's sense of independence. It is difficult, but it's something that you should work with the doctor to help do. The other danger is what I call wandering. Again, when I work with a family, I want to understand the person's sleeping patterns in the evening. Is there a risk of them wandering in the evening? What are they doing? Because if they're wandering, could they fall down the stairs? Even if you're living in an apartment, could they walk out of the apartment? You know, it's important to know, like, is there chimes? Is there an alarm system going on? You know, with oftentimes with older couples and caregivers, they start sleeping in separate bedrooms because it's just too much. It's just too tiring because the person wakes up so frequently. So is there any risk of the person leaving the home? Every week in the news, we hear about an individual who has left home in the night. Okay, so even if they're in an apartment building and if there's a doorman downstairs, you should advise the doorman that, you know, that you have a family member who has dementia, just so that somebody, if they notice them getting up at 3 or 4 o'clock in the morning, that they could be alerted to that. So understanding and responding to challenging behaviors, you know, I really believe that, you know, as the disease progresses, the person will unfortunately lose their communication skills. It's harder for them to put their thoughts into words. And that's often the early signs where challenging behaviors come, because they're frustrated. They're feeling an emotion. They're feeling something going on, but they can't express it. So it's important for you to identify the person, their life story. Who is this person? What are their likes? What are their dislikes? What are their happy triggers? Like, what makes them happy or what doesn't make them happy? Because when it comes to the time where they're going to be losing their ability to express themselves, you'll have to become kind of a detective. Why are they upset today? Why are they anxious today? Okay. Challenging behaviors also occur. It's the nature of the illness. The disease is constantly evolving, right? So things will change. But when they're losing their communication, they may have a day where they've got an upset stomach or something's going on and they can't express it, right? And also challenging behaviors happen because the caregiver, so the spouse or the grown-up kids, maybe you're just nagging them too much, right? You keep telling them, why are you doing this? Don't you remember you're doing this? So if what they are doing is not bothering them or not hurting themselves or others, you've got to learn to let it go, right? My mother would spend all day making her bed and redoing her bed or changing her clothes. And like, so what? Okay, so you have to say to yourself, so what? If at one point they start eating with their hands, so what, right? But if you keep reminding them that they shouldn't be doing this and they shouldn't be doing that, you are going to get a rise out of them. Okay, so it's really about looking at your own energy and your own patience and saying, is it worth starting an argument about that? The other thing that I think is important is once in a while to use what we ought to call the compassionate lie. So meaning if what you are going to tell them has the opportunity to cause a catastrophic reaction from them when they're advanced, why do it? An example would be if they keep asking, if it's a spouse whose spouse passed away many years ago and they say, oh, where's my husband, where's my wife? And if you tell them, well, they've passed away, if it's going to cause a catastrophic reaction, why do it? Why not say, oh, they're on a trip? You know, maybe they'll be back in next year. But I think everybody has their own issue. Like sometimes when I do consulting with families and the caregivers talking to me on the Zoom and their loved one walks in, sometimes they say, don't come in here, I'm on with the dementia consultant. Like you don't have to say you're on with the dementia consultant, you can say I'm on with a life coach. So sometimes it's just about thinking before you speak. Okay, it's really important. But most of the time I think that you need to look as a care partner with your own energy, right? If you haven't taken a break and you're feeling yourself getting really, really frustrated and angry, it's time for a pause. So activities are really, really important, okay? I'm so excited because we just launched last week a fantastic program for all of you, which is free. So we have this fabulous activity booklet. It's on our website. It has 40 different leisure and recreation activities that you can do at home with your family member, or you can have the grandkids do with their grandparents, for example. And it's really according to the person's stage. So these are examples of the different kinds. So last week we launched these activity videos that you could find on our website. And I'm just going to show you a brief introduction to the videos. I hope there's sound. So I really encourage you to go and have a look at those videos. It's about just participating in life, and social stimulation is key, right? If somebody is being isolated at home in front of a television, or isolated in their apartment, or not seeing friends, it's not healthy. And these activities are also being used by some of the healthcare professionals that work in residences as well. So please go and use our videos. So here are some key points that I would like to go over with you. So the journey of a care partner is really about proactive planning, okay? And what is our expectation? When I was caring for my mother, what was most important for me was that she be happy in whatever sense of the word happy is as it goes, that she be safe and that she be clean. That was really, really my objective, right? And a lot of people stay in a state of denial. And this could apply to other illnesses as well, right? You can't believe this is happening. You're trying to, you just want to be in a state of denial. For those of you that are sandwich generation caregivers like I am, I'm sure, and oftentimes there's the healthy mom or dad are in denial that anything is wrong, right? But you really, in order to move ahead, you have to try as best as possible to accept what's happening and to say, many thanks, I'm not there. You're just delaying care. And I cannot enforce enough that when you do have that doctor's appointment, please arrive prepared, especially if you're going for the first cognitive assessment, okay? The doctor needs to have as much information from the family member as possible. Don't do like I did, where I arrived, I did not have my mother's medical history, I did not have a list of
All about
medications,
dementia.
right? Like you need to have as much as possible the information available to the doctor, and then don't leave the office until you ask for next steps, okay? So it's to be prepared, right? And oftentimes the second and third appointment is even shorter than the first, because a doctor oftentimes has to see 10 patients in an hour, right? So you don't have a lot of time. So please make sure to arrive prepared. And again, as I mentioned at the very beginning, knowledge is the most powerful resource. So understand the illness. If you're in one stage, understand what's coming next. Understand all the fabulous resources like NOVA that are available in the community that can help you. Don't wait to get to a state of where you're in a crisis and then all of a sudden you don't know how to access resources. So there are incredible organizations like NOVA that are there to help you. The other thing is it's about, well, in Quebec, we talk about navigating the healthcare system. So for those of you that live in Quebec, it's important to have a file open with the CLSC. The only way to go into a CHSLD is via the CLSC. So make sure that you need to contact your CLSC to open a file and plan for the future. You know, a lot of people, everybody wants to live at home for as long as possible, but it may get to the point where it's just not possible to stay at home. So do your research, have those conversations with the person, understand their wishes, their advanced care planning wishes, make sure that all of your legal affairs in order. And it's one more reason that it's imperative for you to have that assessment from the doctor, because if you don't have the assessment for the doctor, you're not going to be able to have a homologation of a mandate. There are so many legal documents that you will need to make decisions on behalf of your loved one. If you don't have a doctor's assessment, you will not be able to make those decisions. And advocating for a person really becomes the primary role. As the person's disease progresses and they become less able to represent themselves, that's where your role comes in. Just because my mother was transferred to a residence didn't mean my role stopped. If anything, I had to even advocate even more for her care as she wasn't able to continue. And I can't emphasize the importance of identifying support for yourselves early on, because if you don't identify support for yourselves, what I call the anchoring effect happens. So the person that you're caring for, they will only want you. And so the longer that you wait to get third-party support, the harder it will become for you to finally get that support you need. So please make sure to identify as much support as possible. So this was an example of me. I did not have any support. I was the caregiver with the 3 young kids, and I was multitasking all the time. And I kept telling everybody I'm not there yet. You know, I was pretending that everything was great when it really wasn't. And I end up suffering a real burnout. And one emotion that I hear a lot from family members is about how angry they are. People say they feel shame to say how angry they are, but anger is probably one of the most common emotions, okay? About how could this have happened to my husband, my wife, my mother or father? How can this have happened to me? There's also cases where you may not like your mother or father and you're put into a role where you have to take care of them, okay? And also finances put a big strain on people's lives. So anger, please know, is it's probably the most common emotion. It was one that I went through. And it's important to be mindful of coping mechanisms, because almost everybody has a coping mechanism to manage the stress, right? And we go through this cycle of first we are in denial, and then we feel guilty about everything, and then we're grieving, and then we feel isolated, and then we feel anger. And the way we cope with our anger, whether it be alcohol, drugs, smoking, eating, shopping, we wake up and feeling shame, okay? I need you to know you're not alone, but be mindful that the coping mechanisms do not become dependencies. And finally, the importance of self-care. The most important person on this journey is the caregiver, okay? Because if you don't take care of yourself, you will not be able to take care of the person that needs you the most, okay? And for whatever reason, we don't give ourselves permission to have some joy in our life. But remember, if you don't take care of yourself, you are going to impact the quality of the care that that person will have. And I suffered a very severe burnout halfway through the journey caring for my mother. And I had to really learn how to take the best care possible. So if I can leave you with 2 points, the first point is really take a look at your life, and as much as possible, surround yourself with people that are bringing added value to your life. Sometimes there's family members that you can't avoid, but I would say try to have lunch with the toxic people, and as opposed to dinner, because lunch is shorter. And the second of all is let go of projects or commitments that are really not adding value. If you're volunteering for something, or you're involved in any type of organization and you're just not into it anymore, it's okay to say no, and it's okay to let go, because unfortunately, as the disease progresses, it really is going to require a tremendous amount of energy. And finally, guilt serves no purpose on this journey. I need to say that again. Guilt serves no purpose on this journey, okay? And guilt often prevents us from making those important decisions, such as maybe understanding it's time to transition a person outside of the house, okay? So this disease becomes harder on the caregiver as it goes on than it is on the person. So I'm going to leave you with that. Thank you so much for listening to my presentation. And like Nova, we too are dependent on the public to support our program. So if you'd like to consider making a donation to the McGill University Dementia Education Program, that would be great. And now we look forward to having questions from you.
Thank you so much, Claire and Dr. Gauthier. So we do have quite a few questions in the chat, as well as some that we received in advance by email. I'm going to start with an easy one. What is sundowning?
Oh, I can give a quick answer if I may. Sundowning is a common phenomenon where people get restless when it gets dark. It's particularly notable in December in our latitude, because the days are shorter. And some ways around that is simply to have more light in the house. It's also a factor in seasonal depression. This is very common in Scandinavia. So Finland, where Claire has some ancestors, some houses are full of neon lights and bright lights. And finally, there's even light therapy for depression. So more lights, especially December, not just the Christmas tree, but also just white light is good for everyone.
Wonderful. Thank you so much. So we had a few questions about some of our participants who are asking, where can you go to get help, particularly if you have a loved one who is in denial, who has agnosia, and who has perhaps, there's perhaps safety concerns, like issues of violence or paranoia. So what would your advice be in terms of trying to get support for the caregiver for
Now
that?
you deal with that every day, so go ahead.
Okay. Well, I mean, in terms of organizations that are offering support, I mean, because I know that there's listeners from all over, I would really recommend that you go to the Alzheimer's Society of your region. For those of you in Europe, there's wonderful Alzheimer's societies across Europe. There's the Alzheimer's Association in the United States, and within Canada, there are really excellent Alzheimer's associations. I know that I believe Nova may also have some support groups, but you could correct me if I'm wrong. And I encourage you also to take time and look at our website. The McGill Cares webcast that I've produced, we have over 100 webcasts on all kinds of topics. And we also have virtual support groups that you're welcome to join in. We have another program called Caring Conversations, addressing these types of different topics. But with the anosognosia, what we're most concerned about, once again, it's the person's safety, okay? So if what they are saying and what they are doing isn't hurting them, let it be. However, if they're still driving and they're managing their finances and that's becoming a significant problem, you must go and speak to the doctor, okay? And another word of advice is try to get in touch with the doctor prior to the appointment if it is of concern like this, because you cannot bring your mother, father, spouse and talk about them in front of the doctor when they're going to be in disagreement with you. So today we could try to email the doctor ahead of time or email their coordinator and say, this is what's important. I'm having this issue, so that when you go to the doctor's appointment, the doctor's already prepared, and the doctor could say, you know, the illness is progressing. It's important now that you stop driving or no longer manage your finances.
A quick bit of extra advice from a clinician perspective is sometimes we have an appointment given to both a couple, and we say, look, it's a checkup, and then we take the opportunity to start the discussion about memory problems, and maybe we break the ice, and the person is happy to come back for their own appointment. Yeah.
Thank you. So we do have a question about what the lead time would be to see a neurologist for dementia. I guess one individual has been waiting over a year and a half.
Okay, I can answer that because I just had a webcast with the Fédération des médecins spécialistes du Québec. If the question is from someone in Quebec, and it's going to be faster because now it's going to be online, a review system for referrals. So family doctors will be able to enter the MOCA score, the MMSE score, and basic information. The short answer also is the younger you are, the more quickly you will be seen. So anybody younger than 65 will be seen as a high priority. And a little advice, the more atypical you are in the symptoms, the quicker you will be seen. Little hint. So if you want to help your family doctor to write the referral, say there are atypical features in this 70-year-old person, and enter the MOCA and the MMSC, and they should be seen within 6 months in the new revised system.
Thank you. That's encouraging.
I would just like to add, and we didn't bring it up, but I think it's really important. If the person that you're caring for starts to display any type of verbal or physical type of aggression towards you, please don't wait. It's important you can go to the ER actually with them. You know, if something really changes, significantly changes, you know, again, you can go to the emergency room, but anybody, please, if there's any type of physical aggression that starts to happen, go straight to the emergency.
I agree.
Agreed, yes. We have a question about a woman whose mother self-harms, mostly by damaging her skin, and she was told that anxiety and medications are not desirable, and that the antidepressant that she's on briefly doesn't seem to help. Are there any approaches that you could recommend for a patient like this?
Okay, sorry, I missed the early part of the question. Is this the issue?
Yes.
Is there's a side effect, like the person is scratching herself a lot and
self-harms, so that could be
self-harm.
cutting or yeah.
Okay, so
Yeah.
self-harm, that's not specific to dementia. It could be seen in a number of psychiatric disorders. So ideally, you should ask the family doctor and the consulting psychiatrist, and together they will work out something that may help.
Thank you. And we have a question about how to restore trust. If a person has become paranoid and no longer trusts their caregiver, do you have any advice on how you can help convince them that their caregiver is not stealing from them or is not trying to take anything away?
I hope you have an easy answer.
That's again, that's part of the anosognosia, and that's really difficult because most people don't want to have a caregiver come into the house. Okay, I mean, most people, when a family member is going to try to introduce care at home, the first reaction is going to be no. I don't want this person. And again, you know, if you start arguing with the family member, it doesn't work. Ideally, you work with an agency or like Nova or something where you try to really find a companion that's a good match for the person. I mean, if they are really becoming distraught, perhaps it's the energy of the caregiver and they haven't been trained. I mean, you want to find a caregiver, a professional caregiver who's had some training in dementia that could handle a person that has some paranoia. But again, you know, sometimes it comes down to really tough love. I mean, your number one priority is the safety of the person, and their go-to will be, no, I don't want this caregiver. I don't want anybody coming in my house. So it's about the safety. If the paranoia becomes extreme, once again, it's important to go see the doctor so that the doctor could perhaps give them some medications to manage it. I mean, again, it depends on the level. If the paranoia is extremely high, they should be contacting the doctor. Anything to add, Dr. Gauthier, to that?
You covered it all. I think the question was among family members, but you were right to mention caregivers, care partners from outside also can be an issue, and training helps. I don't know if we can ask Dominique or Marianne if their experience also, you have a suggestion how you approach people who are a bit afraid of strangers?
I think Claire cover most of what the home health aides are doing at Nova, but really trying to work with also the family member of the person when a home health help goes into the client's house, and really trying to focus, for example, on how what's the person want to do, and trying to rebuild that connection with that person through their own experience of life. So,
bring out the pictures from the wedding and nice events in their life,
yes,
and
yes, absolutely.
bring a dog.
And the booklet, also the McGill booklet that Dr. Gauthier and Claire mentioned, is extremely helpful. We have, all of our clinical team is using it. It's being shared with all the families and caregivers that we're helping. So it's an invaluable tool.
Wonderful. So I'm just going to ask one last question before we wrap up. This is a question that we received by email. So it's about a woman whose husband was diagnosed with frontotemporal dementia at the age of 85. So there's two parts to the question. The first is, at this age, does the disease progress faster? And the second part of the question is, unfortunately, the woman had a daughter who died of ALS at the age of 45 with the same gene. So is there a genetic correlation?
Okay. These are very good questions. So the first part can be generalized. So over age 85, you die of something else than dementia. And to make it short, you have other conditions associated with age, such as your heart, your kidneys, or you fall, you break a leg. So it's a different kind of progression than someone who's 65, where yes, you will die of complications related to the dementia, such as swallowing difficulties, etc. Also, over age 85, you have mixed dementia more commonly than a specific cause, such as Alzheimer, or a genetic cause. It's a mixed picture. And if you treat the vascular risk factors, also you stabilize the progression to some degree. As far as people who have inherited the same gene, especially in the frontotemporal dementia family, the genes have different effects on people, and you may have different age of onset. I can also add that even people who have the same gene causing Alzheimer at age 40, let's say you have brothers and sisters who have the same gene, they may have a different age of onset because of one stayed in school longer, one never drank alcohol. Lifestyle does modify your risk factor. So a practical message, perhaps, of hope, even if you have in your family people who have Alzheimer around age 70, 75, you may have inherited from that side of the family a gene that increases your risk, but that can be offset, managed by changes in your lifestyle. So look at the 12 preventable risk factors, and it will have an impact on the age where you get symptoms, and then you'll die of something else.
Wonderful. Thank you. Thank you so much. So with that, we're going to wrap up today's lecture, and we are so grateful to everyone who took the time to join us today to learn more about Alzheimer's disease and how you can look after yourself as a caregiver. Thank you, Dr. Gauthier. Thank you, Claire. It was really nice to have Marianne and Dominic here with us today to learn more about NOVA. So if you have any questions at all, please don't hesitate to email us at dementia@mcgill.ca, and we'd be happy to try to provide you with some resources. Thank you.
Thank you,
Take good care.
Merci, Nova.